Okay, so let's jump into our didactic. Um, so thus far, what we've done is we've sort of looked at TIIPs. We've talked in the past about the epistemological framework. We've talked about sort of the ontological framework, and then we tried to go and become a little bit more practical on how this might actually and what this might look like for working with patients. And so. I had this chart created, right? And this was this particular form that I have is really for a situation, right? So you can like we demonstrated in the past two didactics, you can do this for a specific situation, right? Like for example, I had given you guys the example of my client who had anxiety about traveling, right? This is prior to the corona, by the way. So it was irrational, unreasonable kind of traveling issues. And then the issue of, losing sleep and then sleep, therefore compromising, um, uh, not being in the same bed, and then therefore losing sleep, being irritable, and then ruining his whole 1 week vacation, for example, and then deciding not to go. And so we talked about that, and that's a situation. And then we look at the more specific thoughts and behaviors and emotions, and spiritual experiences that are associated with that specific scenario. um, and what we can also do then is, and we won't use this form for this, although I guess you could if you remove the situation part. Um, but what we could do is kind of get on a board like we did before to case conceptualize the patient, and just looking more broadly at all of the different elements of their psyche, and looking at functioning across each of those domains, or the different facets they might be prone to. You might look at their thought process, and they might do catastrophization, right? They might catastrophize a lot. They might maximize or mind read, or these are some of the cognitive distortions that they might be doing. They might have su'u dhan, for example, right? Negative thinking, or pessimistic, or looking at people through sort of a negative filter. You might have on their emotions like a general pattern of avoidance, right? So we're looking at more general patterns. Now, when we get into a situation, you can take avoidance as a situation, right? And you can take um, you know let's say social interaction, right? That's a very specific avoidance. And then we might talk about social interaction at work, right? So you take a very specific situation, or with a relationship like we did, and we can look at the different aspects of the individual. Now let's talk about the processes of change. For some of you who many of you have seen this before. However, this is slightly revised. So this is the more updated version. And what we tried to do was to actually have the 4 eyes on the top, and M's on the bottom. Okay, so on the top part, it's the and this whole chart is sort of our mechanisms, or rather process of change. So we've talked about the conceptualization of the individual, but what are the broad kind of big uh, uh, principles and mechanisms of change? And this is in a kind of a stage-wise fashion that it's listed. However, it's not like a hard and fast rule that it has to be absolutely done this way and only from step 1 to 2, 3, or 4. It's just that this is the more typical process that we would utilize and observe in a client, or working with a client, and it has a rationale as to why these things should occur. in order. However, of course, in some circumstances, case by case, you might need to alter that. So let's start with, on the top, the principles of changes with the patient. So we're looking at the patient experience. What are we hoping to facilitate in the patient? And then on the bottom, we have the mechanisms of change, and that is, what is the practitioner doing in order to facilitate that change in the patient. Okay, so, and then on the bottom we have health and pathology, all the way on the bottom, and that's and this doesn't you know, may or may not necessarily kind of line up with the above, right? You can think of this as, you know, perhaps it would have even been better for a slideshow just to kind of break up these two so that they don't seem that they're necessarily associated with the above two, you know, parts there. So that I've talked about before, which is more of kind of looking at the continuum of health and dysfunction, right? So we can have, you know, you can go from the clinical range all the way to being very resilient, right? Spiritually, psychologically, and, you know, behaviorally. You might be, you know, very resilient and have a high degree of well-being. And then, of course, there's sort of the normal range, and then there's that which is not in clinical pathology, right? We might talk about narcissism, but not narcissistic personality disorder, for example. And that might be character traits that are problematic for an individual, and it creates problems for them, right? In their relationships, in their functioning, it might impact them. I talk about su'al dhan, right, as sort of a, or you know, more of a spiritual sickness, right? But they may not necessarily be having the kind of negative perception and thinking that leads to clinical depression, right? So this is where we have more of a continuum of pathology. And this we've mentioned that this is a range of exogenous psychological functioning. Why? Because this is more so for those things that are more associated with having a psychological origin, often through social learning or socialization, combined with potential, you know, of course you can't completely separate biology and environment, right? Nature and nurture kinds of experiences. But we're talking more about general loadings, okay? So we can think of even depression as having generally circumstantial, you know, like an adjustment type of depression, or even depression that is in response to like a traumatic event, or you know, chronic grief that has turned into clinical depression, you know, circumstances, adverse circumstances that may have led to that, or even some socialization factors, versus like a biological, strong biological propensity to experience, you know, depression, and therefore, and it's non-remitting, right? It's treatment resistant, very intense, oftentimes needing medication as well. So the reason why we didn't mention sort of the reason why we mentioned this is applicable only to those issues that mostly load on more of a socialization or psychological basis of pathology, is because of the fact that you can't necessarily make this a sort of this continuum for somebody who has a biological propensity, or let's say, for example, schizophrenic, right? Can we say that they are, you know, they're not awliya, they're not a waliullah, they're not friends of Allah? Do you see what I'm saying? Is it, can we say that such individuals lack iman, right? There's a lot of this discussion that happens around, mental illness, it's just based upon weak iman. And if you have more iman, then you wouldn't have mental illness. Well, then there's other people that say, no, that's not true. That's just shaming people and guilting people, and we should have a lot more compassion for people who have mental illness and whatnot. Well, there's kind of evidence on both sides, right? And on the one hand, there's evidence for the fact that individuals who have, use positive religious and spiritual coping, right, also are more religiously engaged, utilize religious coping resources, whether it's cognitive or spiritual or otherwise, tend to have more resilience against psychological disorder, right? It serves as a positive kind of coping mechanism for them as relief from psychological distress as well, right? So then one might say, look, there's a relationship between the two. Certainly there's a relationship between the two, but the question is, what is the relationship between the two variables or the two factors that we're relating? So now when we look at, psychological coping or with somebody using spirituality with somebody who has, let's say, schizophrenia, right? Is it useful? It may be useful, but it may also not be very useful for them, right? And it may not necessarily have the same kind of effect as somebody who's sort of struggling with coping with loss that's depressed as a result of it. And so the other people will say, see, this person hasn't missed a single salah in the masjid, hasn't missed a single fast, and yet they still have mental illness, right? And that's the other side of it. Those that take the other side of the, argument. So this is to really break it up and to say, yes, there is a relationship, but that relationship is really between, when we're talking about when we're talking about those things that are, again, we can't make a completely separate the two. There's a continuum between biology and psychological origin as well. But we can say that when we look more on the continuum or end of the biological, then we're going to see less of a strong impact of spiritual coping there. Versus when we see somebody on the other end, psychological socialization or adjustment or environmental basis of their psychological condition, then we're going to see a lot more impact or positive impact between, say, Iman and their spiritual coping resources and their experience of function or dysfunction. Now let's go back to this principles of, or the process of change, right? So on the top we have inqiyad. This is for the client. On the bottom of that we have murabata. Okay, and I'll explain these terms because these terms are utilized in the Islamic tradition, oftentimes in the field of tasawwuf. However, the way that we're utilizing it may not necessarily be, it may be influenced or drawn from those ideas, but again, remember, we have different scopes. We're bringing it into a different scope of utilization, right? And so what do we mean by this? Inqiyad is, thought of between, say, a practitioner, if in the context of tasawwuf, it would be murid to their sheikh, right? And the murid to their sheikh would have to follow, or the sheikh would have the right of the murid ultimately complying with their prescriptions, right? That you choose to adopt this modality of spiritual treatment or spiritual growth or spiritual or take on the spiritual path, and you have to comply with some of the prescriptions of what the sheikh is offering you, right? In our context, it's treatment compliance, right? So if the patient does not have motivation for change, right, if they don't have an interest in change, if they're not willing to, and sometimes I tell family members this when they want to bring in a family member, and they say, uh, what's the likelihood of they're actually improving, and we're talking about whether they want to be in treatment or not. And I'll tell them, if a person does not have the motivation or interest in wanting to undergo this process, you can have, the master clinician of the world work with them, and you're going to have very limited success, because they might have the best prescriptive measure to give you, but if you don't exercise it, you're not interested, you don't want to engage in that process, then you're not going to benefit from it. So the intervention may be effective, but it's kind of like if you give a person a pill to use, the pill might be effective for that condition, but if they just spit it out, as soon as they walk out of the room, then it's not going to have much of an effect. And so what do we want to do in order to, then what does a therapist do, right? What does a practitioner do? What we want to do is engender motivation and engender compliance, right? And how do we do that? And that's through murabata, which is essentially building the therapeutic alliance. So murabata is a rabt between two things. This mufa'ala form, and you'll see this across all of them. It has the benefit in the Arabic language of having mutuality, that both sides are engaged in something. Right? So for example, muqatala, right, is mutual fighting, right? So as opposed to qital, as it just sort of could be from one side, right? Somebody going and fighting from one side. Muqatala would be fighting from both sides, that both people are engaged in the process. So the murabata is that both people are engaged in building this relationship, but we're thinking of the sort of catalyst, and the person engendering that process is going to be the practitioner that is trying to build that relationship. There are other usages of these words, just so you're aware, like like for example, rabita, right, is a term that is used. I know that the Turks use this term for a particular idea, and some tariqas use this term for a particular idea, so that it's not confused with that. I believe in the Indian subcontinent they often call this tasawwur al-sheikh, right? So meaning that it's sort of a idea of imagining the sheikh or the practitioner, and they take one of the examples I've heard is like where Yusuf alayhi salam has a vision of Yaqub alayhi salam when Imra'atul Aziz, the Pharaoh's wife, is trying to seduce him, and the Mufassirin say that it was kind of like an image that came to Yusuf alayhi salam, where he was like kind of like biting his fingers or making a gesture to be like, don't, right? Like, don't do that. And that image was powerful enough for him that it served as a preventative measure that I'm going to like distance myself, or was sort of reinforcing the notion that I don't want to do this. Now in tasawwuf, it's a much more technical concept, meaning they take this notion, right, and this sort of concept of imagery or meditative imagery, and what they might do is imagine, for example, that the sheikh is sitting like right across from you, right, and like a knee to knee type of thing, like they say, where Jibreel alayhi salam was sitting knee to knee with the Prophet sallallahu when in the hadith of Jibreel, right, when he came and he asked them, Mal Islam, what is Islam? What is, ihsan, right? What is Iman? right? The 3 questions. And they sat knee to knee. So they sort of oftentimes try to resemble this kind of notion, sitting knee to knee with the knees touching in a non-corona environment, right? But, you know, and this idea that there's a transmission from heart to heart type of thing happening. And so one would just sort of meditate on this, actually, like in the privacy of their own home, and imagine that they're sort of knee to knee with their sheikh, or sitting across from their sheikh, and that there's this like, and you imagine the sheikh, and that there's sort of like a transmission of spiritual benefits or energies kind of being transmitted or benefiting from the sheikh spiritually. This is not what we're intending, right? I'm just sort of giving you letting you know this, because if you might present some of these ideas places, people may ask you about these notions, or is this what you intend, or is this what you're doing, right, with the client? No, we're not, but I may not have ever expressed the actual disappointment, but there's certainly a sense of, I don't want to disappoint him, right? And so there's this aspect of it. But for our end, like, we're thinking about the therapeutic alliance that we're trying to build, and we're trying to set up that relationship. And so in the early stages, we often don't want to be very directive. Oftentimes, I mean, post intake and intake, we're directive in gathering information oftentimes, but we often don't want to be very directive at the beginning, especially because what we're really trying to do is to sort of build that relationship. And through empathy, we're able to understand what their experience is like. And oftentimes through empathy, what we end up doing is lowering the guards and defenses. We have to kind of think about, individuals are coming to us with very personal problems, potentially never revealed to anybody. And the idea isn't, and oftentimes a huge story behind it, right? And if you think about it, oftentimes people, those stories and pieces of information are really important for them, for you to understand what this feels like or what this experience is like. So it's not sufficient to say I kind of got the gist of what's going on. And then even if, like, you've had a trained ear where you've seen this similar type of case, for the 100th time, if you go straight into treatment of the standard protocol that's effective for that particular issue, missing the fact that they need they need to feel like you understand them, right? Not that you do understand, because you may fully understand them, but they may not be sure that you do actually understand them, right? Until that's communicated to them, or they feel that process, they may not necessarily be willing to kind of, they may have their guard up, they may have their defenses up, they may not be willing to engage in the process as much. Maulana Bilal had mentioned in providing, kind of a spiritual prescription, and he mentioned 3 things. It was ta'lif, ta'rif, and the third was taklif. So taklif, the third, being the actual prescription. So making somebody responsible, right, or placing a burden or a burden of responsibility upon an individual to do something. Prior to doing that, there are 2 aspects, and that is ta'lif, which is building, or joining kind of the hearts, right? Building the relationship, so to speak. Ta'rif is the explanation, actually making the person aware of what it is that you're actually going to be administering, and then giving them that protocol, or placing that burden of responsibility upon them. So yes, it is very similar to that idea here, where there's a process of inqiyad, right? Murabata, building the relationship, which ta'lif is built within that, right? And then we kind of move on, because we're not going to give, and we'll get to, what you call, what you mentioned as taklif will be mu'alaja here, essentially. But and the ta'rif is also essentially more closely going to align with, say, the mukashafa part. Although it's very important, I tend to do this a lot upon early sessions to be able to inform the patient as to what process they're going to be undergoing. Like, you may not necessarily place a specific burden on them to say, you need to do this, this is your prescription, but at least giving them some education about the process. And, I cannot overstate the importance of this. People that come to therapy, like, we tend to go into this notion where we know what therapy is about, right? And what we're going to be doing and how it works or what this might look like. But many people do not, right? And so when we make that assumption, that's that's highly problematic. And it also is going to determine, I believe, be a predictor of whether they'll come back or not as well. So you have to consider this. You're going to be empathic. You want to gather a lot of information. Try to generate motivation. Remember in our early sessions, there was a presentation we had given on early sessions. There was kind of 5 things that we talked about. You're doing assessment. You're looking at motivation. You're you're gauging their religiosity, or at least their overt religiosity, in order to be able to, whether you utilize, or their education, religious education, to utilize religious terminologies or not. But also we want to give them some education about the process. Like, here's what we're going to be doing, right? And some descriptor of what you understand of their problem. So feedback about the empathy. So by the end, you want to say something, I'm hearing that, you've gone through X, Y, and Z circumstances. You're experiencing this. So make sure you're speaking to sort of the experience or the distress that actually brought them through the door. And why are they there? Because they want relief from that thing they're experiencing. So you want to communicate, I understand what you're experiencing and the pain associated with it. I understand where it came from, or some of what contributed to that, now that you've told me. And now here is the way that we might approach this, okay? And if you're going to take a very non-directive approach, that's fine. In the early session, even if it's as simple to say, over the next few sessions, what I'd like to do is to try to understand or unpackage this a little bit more, so that both of us can have better awareness as to, the origins or the nature of this, of your distress, right? Or do you have any questions, right? They might ask, what's your success with this? Like, how long will this take? You want to be able to relieve that room for the discussion of the process, which is very important. You may, at the end of the session, pull out this chart and sort of map it for them too. Say, here's what I'm hearing you're kind of experiencing, in your thinking. Here's what I see you're experiencing, as a behavioral reaction. Here's what I see the spiritual impact of this upon you, and the emotional impact. Does this seem to kind of cover it, right? And you might give them some general notions of what we might try to do to make that process better. And I oftentimes have a different script for different types of issues, right? So you might, for anxiety, I might talk about it a certain way. For depression, I might talk about it a certain way. For trauma, for marital work, talk about it a certain way. But make sure you're communicating that to them. It gives them reassurance. It makes them trust you more, trusting that you know what you're doing, and you have expertise, right? So that the person isn't just thinking, this person, I don't know if you've had this, you've heard people say this. I've heard people that go to therapists that come back, and I was like, what was your experience like? And they're like, just listen to me for an hour. I was like, I don't know. I mean, they didn't really give me anything, right? And I mean, it was nice for them to listen to me, but I really don't have a solution to my problem, right? And it sometimes is disheartening for them, or a feeling of like, I wasted my time, okay? please anticipate this, because when you, they may not even give you the opportunity to do it, but you need to make sure that you have the protocol for how you're going to approach the intake session. They may choose to talk about one area or an event that happened in their life, and that's going to take them the whole hour, right? And by the end, they're like, oh, but I didn't talk about this. Well, next week we'll talk about that issue. Well, I don't know where this is going, what the process is, or should I come back? Or do you see what I'm saying? So be sure to have that, you're guiding the process, right? And it is okay to direct the client, not by giving them a prescription, but direct the process. And that's really important. You had a comment or question on this?
I was just wondering, do you guys have a general intake process that is like standardized, or do you guys kind of personalize it according to each one's clinical interests? Or because I would imagine something that would help in this situation is to have a standardized process.
Yeah, yes and no. So we have an intake assessment form which directs or cues the therapist. So there's the intake form, there's the patient intake form, right, that they have to fill out, and then there's the intake assessment form, which is on our end, which you know, for those who you know, might need to use it during the session, particularly I advise it for early clinicians or new clinicians and trainees, so that they know what to ask, right? We need to ask about medical information, we need to ask about substance abuse, we need to talk about prior psychiatric or psychological intervention and history, to talk about social history, about family history, we need to ask about suicidal ideation, homicidal ideation, you know, hallucinations, you know, the mental status examination questions. So that's sort of what we need to ask, but it doesn't necessarily describe the process. And that's more, you know, it's in our trainings, and I've gone through it before. There isn't sort of, and you know, it may be useful, may not be useful to have a sheet that says, go through these notions, go through these steps. Typically having that sort of built in based upon the style of the therapist can be important, and we don't necessarily want to dictate like a very linear approach, because it's not necessarily linear for people. But there were the 5 things that we've talked about in our in that chapter. Remember, Fahad, in the chapter?
Okay, so building the therapeutic alliance, assessment of religiosity, diagnosis and conceptualization, assessment of internal and external psychospiritual functioning, psychoeducation and setting the therapeutic goals, and then assessment of stage of change.
All right. Okay. So assessment of and stage of change is the piece that is associated with motivation. Okay. So, I mean, if in your mind, the 4 might cover it, right?
So again, first is building the therapeutic alliance, assessment of religiosity, diagnosis and conceptualization, assessment of internal and external psychospiritual functioning, psychoeducation and setting therapeutic goals, and assessment of stage of change.
Right. So stage of change is associated with motivation, just so people are what we mean by that. So that's essentially if an individual is sort of in a pre-contemplative stage, right, that where they don't have any desire for change, that's assess versus somebody who comes in and they're prepared for change and they're ready, right? That's a different stage of change. And so we want to make sure that we build that motivation. The 5th thing that ultimately that I didn't mention here was the assessment of internal and external components. So we're looking at assessment of internal, diagnostic and psychological functioning. We're also looking at external, meaning their social environment, what resources, coping resources do they have in there? Are they going to the masjid? Do they have family members? Or do they live in a community? Are they in a rural area? What you know, assets do they have? Okay, next, let's go to the next process of change, and that is from the therapist's end, it's mukashafa, which should facilitate inkishaf in the patient. So it's uncovering. This is sort of an introspective process, right? What we're ultimately doing is Now, this may take place over the first few sessions. What we're really trying to do is uncover their psychological, intrapsychic tensions, where it's coming from, history, underlying kinds of thoughts, underlying beliefs, underlying emotions, right? And we're really trying to do a bit of digging, and hopefully that engenders a sense of self-awareness for the patient as well, that they feel like they understand themselves better and they can conceptualize their own psychological functioning a lot better. Once we go through that, then we go into, now we're prepared for a lot more of the directive interventions, and this is mu'alaja, right? Mu'alaja, so now, we've engendered motivation and compliance from the patient. We've built the therapeutic alliance. We've made them aware of their intrapsychic tensions and what's going on. Now it's time for doing some more directive intervention. Okay, and looking at i'tidal, balance, right? This is where this sheet will be really useful. This sheet, right, will be really useful. We will look at, behavior and balance. Remember last session I did that with one of my clients, and we just did a continuum, right? We're looking at their, we're mapping out their psychological functioning and talking about balance. And then what we're going to do is, consistent with our treatment goals, start to administer them, right? We might do behaviorally exposure, right? If we go back and say, what were the mechanisms of the intervention associated with each of them, right? The intervention for each, we had aql, ruh, ihsas, nafs. We have sort of a overarching intervention, right? Of course, they're going to be very specific for each person, but we're looking at, with cognition, what we might do is cognitive restructuring, right? Restructuring their thought process through education and cognitive contemplation. Through their ruh, what we might do is prescribe some adhkar. What their emotions, what we might do is have them go through doing like chair work, for example, or working on kind of getting past some of the secondary emotions to the primary emotions, and facilitating emotional transformation, right? For the nafs, what we might do is provide some behavioral directives. Like, here is, we may do it in the session, like interoceptive exposures, for example, or we might do exposure therapies. We might prescribe behavioral, regimens, frequencies of what, positive behaviors that they should implement in their environments when they leave the office. These are things that we might do. We might do it in the session, we might do it outside of the session, or prescribe for them to do outside of the session. But what we're really doing is kind of working on addressing the and providing the intervention, and then getting them to i'tidal. I'm going to switch over to the next slideshow because there's, to describe the final one. I'tidal on aql, we have excess or insufficient, right? Excesses or insufficient amounts of things, right? Excessive rumination versus no rumination at all, right? Or we don't call it rumination typically when an individual is kind of, more aware, cognitively aware, or alert, right? On the nafs, we have, excesses, or it might be insufficient, or deficiency. Ruh, we're going to have excess or deficiency. We're going to have on ihsas, excess or deficiency, right? So what we get them to kind of become balanced, right? i'tidal. And then what we want to do, right? And this is our mu'alaja treatment is, in essence, for the most part, kind of done right here. But when we want, now we're going from, let's say, if you want to think of it more clinically, right? Even if it's subclinical, kind of think of it that way, like a dysfunction. If we're thinking about dysfunction is resolved, okay? We've done some interventions. We've engendered some i'tidal, balance and moderation. And now we have psychospiritual equilibrium, okay? Dysfunction is done. However, they may have the propensity, right? كل شيء يرجع إلى أصله, right? That everything, you know, there's a regression to the mean, right? Everything kind of regresses back to its original state. When you've sort of built, habituated yourself a certain way, you're likely to kind of go back, right? So what we want to do is to create resiliency and well-being, okay, after this. We want to create resiliency for, so what we want to do is to get you, rather than just being functional, we want to get you to a higher level of well-being, okay? And for some patients, it might be done there. They're just like, you know what, I got what I needed to come here for, and I'm kind of done, right? And they go away, and they may or may never come back, right? And then, but for others, they may feel like, you know what, I really benefited from this process. I want to keep coming in order to be able to strengthen other areas of my life, or to continue working, right, on this continuum, right, from I'm no longer dysfunctional, I'm kind of, you know, well balanced, but what I want to do is I want to live sort of a more resilient, higher level of functioning, right? And so now we're looking at well-being. We're looking at engendering kind of, a higher level of sort of contentment, and even spiritual engagement, for example. And this is where we might call this process of going to ittihad, and it's through muwasala, right, which is continuity. And if you think about it in the tasawwufi terms, the first is takhliya, right? We're getting rid of dysfunction, okay? Creating moderation. Then what we're doing is we're tahliya, right? Which is adornment, right? Now we've removed, so the analogy oftentimes, like if you get a cup and you have urine in the cup, okay? What you need to, if you pour water on top of it, you pour juice on top of it, then what you've ultimately done is kind of tainted the whole thing, right? So what we want to do is get rid of the dysfunction, right? Get rid of some of that stuff. And now when we put, when we adorn, or we put, milk into the cup, then it's a clean cup in which we're utilizing. And what we're doing is we're having a muwasala, or continuity, right, of continuing, right? Muwasala can have both terms, which is continuity, like, to continue something, right? Like to do wasl between two things. You've sort of take one stage, then do the next, and then do the next piece. So we're connecting the person, right, there afterwards. Muwasala can also be that we're also being a wasila, right, a means or a medium to further growth, right? We're sort of engendering further growth. And ittihad, if you think about unity, right, more of a unity of being, also you have to be integrative unity. We also have to be careful of these terms sometimes, because they may have associated meanings. Again, in tasawwuf, wahdatul wujud has a very specific meaning. Wahdatul shuhud is another concept. Fana and baqa, for example, these are tasawwuf concepts. Just so a lot of these denote a similar idea, and that is that an individual kind of melts their own will and their desires and their own ambitions, right? And they become unified with the will of Allah subhanahu wa ta'ala, such that they forget their own selves. They become essentially a vessel for Allah subhanahu wa ta'ala, right? And we're not necessarily getting at this notion of an individual completely loses themselves, because this is a more specific to the spiritual lodge and tasawwuf work. But what we're talking about in ittihad is this concept of, an integration between parts. Is, in psychology, whenever there's a disintegration, right, or fragmentation of the psyche, it tends to not be very useful for the individual, tends to lead to psychological distress. What we're looking at is, like, if you say each one of these components are in moderation, aql, nafs, ruh, ihsas, ittihad, you can kind of think of these as all lining up now. You see, as we line them up, okay, now they're all in moderation, but like beads on a tasbih, right, on a prayer beads, they're all lined on the same, they're united and connected by the same string. You see what I'm saying? And kept together. And so by keeping them together, what we have is this sort of integration and merging whereby all of these functions, if you can think of like the tasbih, right? But then what happens is, think of like a Play-Doh tasbih, okay? And then what you do is you take the balls and you kind of like, what we've done is i'tidal, line them up, right? So they're in the middle. And what we're doing is we kind of merge them together, okay? And we merge them together, we form this big ball, okay? And when you form this kind of big ball, right? What you have is that they're all functioning together to fulfill the same aims, right? You have a unity of your purpose, and now you're functioning, of course, guided by our religious aims. We're ultimately trying to please Allah subhanahu wa ta'ala, but all of our aspects of our aql, nafs, ruh, ihsan, all these things sort of come together in order to build a unity of being, kind of in our functioning, in our daily functioning, that we're not having this sort of internal discord or tension or conversation between different parts of ourselves, right? And the nafs might be moderated, the aql might be moderated, but they might still have different kind of drives that they might, right, even if they're in moderation, right? And what we want to do is we want to kind of transfer and unite these things together so that they're serving the same aims and the same goals. So that's the processes of change.